Thank you for joining iMeet.
Hello.
This meeting is now being recorded.
Jessica?
Hello.
Hello, Jessica?
Hi, how are you?
Good, how are you?
Good. I did receive your slides last night, so I'm uploading them as we talk.
Okay, great.
Okay, and then you were able to access everything and it looks good?
Yeah, I even got a new computer last week, so I had to reload it all last night.
Oh
but I think
no.
we're in good shape.
After all that.
I know. It was a good first run, so I had it under control now.
Okay, good. Perfect. So this is a large PowerPoint, as you can imagine.
Sorry. Yeah. I felt bad. I don't think it would have gone through on my Outlook account.
No, it's fine. Are you and your residents in the same location?
We will be. I don't know where she is, but she's coming.
Oh, no worries.
I hear her voice down the hallway.
Okay. Talk to you later. Thank you. Taking forever to upload. So I remember we talked about this and I can't find my note on it right now. Did we say we want to ask people to raise their hand or type comments in the room box?
Whichever, I don't remember what we decided on, whatever you think makes more sense.
Okay, I'm sorry, I can't remember.
I think we talked
Which
about
one we
like both options, but yeah.
Okay. So I will, I'm going to do the first about 10 minutes, and then the rest will just be everything you have prepared.
Okay.
Okay. I'm going to try to get through the beginning in less than 10 minutes, but I anticipate we might have some questions with the data.
Okay. Mm-hmm. Just like. We only get. I think she does them, right? Or no, we do them. No, I don't. Jessica?
Yeah.
Just because we didn't practice like moving the slides, do we just use the arrow buttons on our computer?
Yeah, or at the bottom, here, I'll pass it off to you for a second. Or at the bottom, you should see the next option.
Okay. Oh, I see it. Great.
So I just gave you control if you want to try moving it.
Okay.
If you do the arrow, will it work too?
No. It's just it. Sorry. That was me using my arrow keys.
Or like up or down?
Okay.
No. Okay, good to know. You just have to click.
Want me to give it back to you? Is that how it works?
Yeah, that would be great.
Okay.
Okay. Perfect. So we'll just wait a couple minutes to see significantly more people than the 3 of us who are on the call I know had RSVP. So we'll just give everybody a couple minutes.
Hello.
Hi.
Hi, Jess. It's Cleo.
Yes, I hear that. We're just waiting for a couple more people to join, and then we will start, get started.
Okay, perfect. Is anyone else on the line?
There is. So we have Dr. Johnston, who's going to be giving our presentation today, and then I saw that Paige from the March of Dimes was on, and everybody else is showing up as unknown callers, so I'm not sure about anybody else.
Okay, great.
Hello? Hello?
Hey guys, thanks for joining. We're just waiting a couple minutes to get started with our webinar this morning.
Okay.
We'll probably get started in about 2 minutes or so. So for anybody that has joined us via audio but not visual, we have lots of great slides today from our presenters. So I recommend also trying to get to a computer and opening up the visual component of IME as well. So you can do that by following the link that was in the newsletter. And if anyone has questions, I could try to help you troubleshoot in the next minute or so.
This is Beth Anderson in Williamsport. I earlier this week had IT help me make sure I had the iMeet all set up, and I just keep getting booted out. It keeps saying thank you for attending. Maybe it's because it hasn't started yet. That's why I got on the phone.
Well, it shouldn't cut you out for that. Try logging back in again, but use the option to dial in, not to use your computer to call. So you can stay on this line with me, and then you should also be able to click the link and log in as well. If you're having trouble with the desktop app, you could also run it through the web browser.
Yeah, that's what I did. I think I used the web browser. That's what they told me to do the other day. It's just not working. I don't know why. I'll try again.
Okay. So we're going to go ahead and get started. I would like to thank everybody for joining us this morning. This is Jessica Brubaugh talking, and work as the network coordinator. So we are thrilled to bring everybody together for our LARC implementation, Overcoming Barriers. So I am going to spend the first couple minutes or so talking from a network perspective about LARC implementation question, and then we are going to turn it over to Lawrence, who will be given the majority of our presentation today. Throughout the webinar, if you find that you have questions or anything, down in the bottom left-hand corner of the screen, there is a chat option and also the option to raise your hand. So feel free to use either one of those if you have a question. All right, so getting started, our objectives today are to share some brief network reminders, to present implicit ICC Phase 2 LARC data, to discuss barriers to LARC implementation, and to present strategies to overcome the discussed barriers. So from a network perspective, just a couple brief reminders to those sites that are on the call. Please keep an eye out for an email from your network coordinator to schedule your quarterly site update in the month of February. The 2017 Spring Network is Friday, April 7th in Lancaster, Pennsylvania. So if you get to put that on your calendar, try to mark that down. And the newsletter will be going out this month with a review of our webinar this morning, as well as the release of the March of Dimes toolkit that we've worked really hard in collaboration with the March of Dimes to develop, as well as the RSVP for the spring meeting. So just keep an eye out for those things. And if you have any questions, feel free to reach out. So jumping right into our model today, as many of us on the call know, the implicit ICC model is to repeatedly screen mothers during child visits from 0 to 24 months to assess current risks, to reinforce desired behaviors, connect with primary providers or community resources, to collect and analyze data, to develop strategies to improve delivery and patient outcomes. Our model focuses on 4 behavioral risks affecting future poor birth outcomes: smoking, depression, family planning and birth spacing, and multivitamin with folic acid use. So today's webinar is predominantly going to focus on family planning with a special focus on LARC, long-acting reversible contraception. So for those of us who are collecting data throughout the network, you may have noticed that our data collection tool changed from Phase 1 to Phase 2. So when we started collecting ICC data, we specifically looked at whether or not the mom has been pregnant since this child, whether or not she's currently pregnant, contraception she's using, and we had a little bit more options to choose from, as well as the intervention. But we decided that some of the key things that we really cared about was whether or not mom was on LARC, and then whether or not she was not using contraception. So we simplified our data collection in Phase 2 to look at, has mother been pregnant since the last visit? Is she using contraception, with the options of yes, IUD or implant LARC, yes, permanent sterilization, yes, other, no mother's currently pregnant, no mother's trying to conceive, or no, and then whether or not an intervention was done for anybody who's screened positive. So I wanted to take a break and ask if anybody had questions about the model or how we are collecting our contraception data. Okay, so then moving into our interconception care data and what some of this can tell us. So we currently have 9 network sites that are collecting data and sharing it with the network. Our screening rates do vary per site. For sites that are able to determine if mother is present, they're about 78%. And then for sites that are unable to determine if mother is present, just looking at ICC over the total child visit, our rate is about 68%, although as you can see from this chart, that does vary by site. And then taking a look at the moms we are reaching, we do see that they are predominantly high-risk minority women who are at the greatest risk for future poor birth outcomes. The majority on medical assistance are African-American, Hispanic, have less than a high school degree or equivalent, and are less than 24 years old. But as you may notice, we are missing a significant number of our maternal demographics. So for those sites on the call that are able to collect this, just a friendly reminder to continue to try to increase the maternal demographic collection. I've been working with our implicit data review team to decide what type of data to present during these webinars, as well as different ways to look at our data. And one thing that we've recently done is we have taken a look at the maternal demographics and then risk factor prevalence. So this chart specifically looks at education, and it's a little bit confusing, and for many of you, this is the first time you're seeing it, but essentially looking at women who had less than a high school degree or equivalent, there were 2,063 opportunities, with 612 of those women are using LARC. So of the women who have a high school degree or less, 30% of them use LARC. And then looking at a high school degree or equivalent, 21.5% of women with a high school degree or equivalent have selected LARC as their method of contraception. And then looking at those who have more than a high school degree or equivalent, 17% have reported to be using LARC. And then we do have a significant number of maternal demographics not collected. So that would be the NA column that you'll continue to see at the bottom throughout these charts. Then looking at the next maternal demographic of insurance, of the women who are on medical assistance, 21.5% are using LARC. Of the women with private insurance, 24.6% are using LARC. Of the women who are self-pay, 21% are using LARC. Of the women that are documented as unknown, 30% are using LARC. But then of the women that we've not collected maternal demographics, about 21% are using LARC. So then looking at maternal age, this chart has significantly more options. But what you tend to see is that regardless of what age you're looking at, the majority of the time, about 20 to 25% of the women are using LARC, except if you look at age 15 to 17, you see that 43% of those women are using LARC. So it looks like a high number of our teens in that range are using LARC. And then we did not have any women who reported to be greater than 45. And so then moving on to race, we see that of the women who reported to be Black or African American, 20% are using LARC. Of the women who are other, 24% are using LARC. And then of the women who are white, about 22% are using LARC. And then moving to ethnicity, about 28% of the women who are Hispanic are using LARC. About 22% of the non-Hispanic are using LARC. And then 27% of the unknown are using LARC. So I think one of the trends that you see throughout looking at these risk factors is that regardless of what risk factor you're looking at, 20 seems to be a pretty common number. Does anybody have any questions about this data? If it's a little, I know it's a little bit overwhelming. It's the first time a lot of you are seeing it. So whenever we send the presentation as well as the slides out on the web and in the newsletter, feel free to take a look at it and reach out with any additional questions. So then looking at the question, is mother using contraception? At 22.8% of visits, women did report to be using LARC. And so we do have a high rate of visits where women are reporting using LARC. And then we have about 28% of women who have reported not to be using anything. Of them, 78% did receive an intervention. So we are trying to help women access contraception as needed. Looking at this over time, you can see here our different contraception options. Yes, IUD, yes, permanent sterilization, yes, other, no mother's currently pregnant, no trying to conceive, or no over the age of child, so newborn to 24 months. You'll notice that it doesn't change significantly as the babies get older, although in that first newborn to 9-month period, it does look like our LARC line does trend upwards. Then breaking this down and excluding everything but LARC, this chart takes a look at women using LARC at associated well-child visits. So you can see that from newborn to 9 months, that number does steadily increase. And then it remains pretty steady after 9 months, but something to consider in looking at the bottom when you see the end is that this project is always rolling. New people are always starting to roll into it, and so it makes sense that there are significantly more newborn visits than there are visits at 24 months. So that could also play a factor into why those numbers change a little bit. So one of the things that our data review committee wanted to look at was LARC discontinuation and LARC continuation. So this chart specifically looks at discontinuation. And so what you see along the horizontal axis is you see when women reported to begin LARC. And then what you see on the vertical axis is the end of LARC. And so when you're reading this, you can look across the bottom and you would see that at the newborn visit, there were 20 women who had subsequent newborn visits that reported no longer to be using LARC if they reported LARC. So of the women who received LARC in the newborn time period, 18 of them reported not to be using LARC at 2 months. And then if you just picked, at 12 months, of the women who started LARC at 12 months, 4 of them reported to no longer be using LARC at 15 months. So this takes a look at the women who start and stop LARC, but this includes the women that we may not know whether or not they're still using it. So for example, maybe a baby is still only 2 months old and we don't have subsequent visits for them, or maybe mom moved practices and we no longer have that information. So that's what that top bar looks like. So of the women who received LARC at the newborn visit, we are not sure if they continued to be on LARC for 103 of them. So this is kind of a different way to look at some of our data. Does anybody have questions about this chart? It's pretty interesting because when you look at it, regardless of what time moms reported to start LARC, we do see discontinuation at subsequent visits. So then looking at this chart the exact same way, but taking out the women where we're not sure whether they discontinued LARC. So it's essentially the same thing, but this would be important if we wanted to focus on people that reported LARC discontinuation. And so again, you would read it the same way. For example, of all of the women who started LARC at 2 months, 23 reported no longer to be using LARC at 4 months. So some of those, younger visits are some pretty high numbers. So it'd be interesting to do a more chart review, in-depth analysis of why this is occurring. And then finally, a Kaplan-Meier curve that looks at LARC continuation. So women that we know are still on LARC will remain in the denominator over time. So for example, if we know somebody received LARC at 2 months and then they had it removed at 9 months, they're included in that denominator until 9 months. So the N does get significantly smaller as we go out. But looking at the age of the child LARC was initiative for newborn, that's that red line that you see. We know from the previous chart that 20 women reported no longer to be using LARC. So what you can see is that 87% of women are still using LARC at the 2-month visit, at the newborn visit. If you were to follow that line out to about 9 months, only 50% of women who received LARC at the newborn visit are still using LARC at the 9-month visit. So just different ways to look at our data, to look at continuation or discontinuation. But again, interestingly enough, regardless of when LARC was initiated, we see the same trend. So in summary with our data, we're missing about 57% of our maternal demographics. Women did report to be using LARC at 23% of visits, and regardless of when women start using LARC, women have discontinued LARC at subsequent visits. And so unless anybody has any questions, I would now like to pass the presentation over to Lauren so that they can talk about promoting LARC use and implementation in a primary care setting.
Thank you, Jess. So this is Julie, and as Mina will be presenting, Elise is on maternity leave at this point. So getting right to it, there's a lot of great LARC work already happening. I just have a couple of disclosures. So we're going to talk about improving same-day facilitation of LARC, talk a little bit about billing and purchasing, some postpartum contraceptive options, including breastfeeding safety, and then offering medications to improve continuation of LARC devices. So as all of you know, many pregnancies are unintended. About half in the US are unintended, and the LARC methods are the best and most effective at preventing pregnancy. So in 2009, ACOG actually recommended that same-day insertion occur for LARCs, but when they looked at who is doing them, not very many practices are able and still offering same-day LARC procedures. There was another study of 708 women who were offered, who did for a 2-day insertion, and 45% of women did not return for their IUD. So we are missing a lot of women in general, maybe not our practices. So before we go any further, I just wanted to make sure that everyone is aware of the new LARCs that are on the market. So the LETA is the same dose as the Mirena for 52 milligrams of levonorgestrel. If you have 403B pricing access, it is only $50 for the cost, which is improving access to a lot of women. It has been approved for 3 years, but we do have data that it is safe for 5 years. And because it is the same dose as Mirena, which has been shown to be effective to 7 years, with time we expect that it also will be good for 7 years. And then recently to the market is Kylena, which is also made by Bayer, who makes Mirena and Skyla. And it's a little bit more than Skyla. So Skyla is 13.5 milligrams of levonorgestrel. This is a little bit more, which makes it last longer, so it is good for 5 years. It is aimed at nulliparous women, as is Skyla, and it seems like this perhaps might eclipse the Skyla market due to duration of use. So we're going to start with some information about decreasing barriers. And when we talk about decreasing barriers, I encounter a lot of colleagues who question, don't you need to have the gonorrhea and chlamydia? And nurses, asking the same questions. So going to the most evidence-based source that we have, the CDC selected practice recommendations for contraceptive use. They give us a great chart for what you need to do for each method of contraception. So for the IUDs, the only thing that is required is a bimanual exam and a cervical inspection, which you would need to do if you are going to be putting in an IUD. There's no mention of GC chlamydia. So that is a separate issue, and the recommendation is that you follow your standard CDC screening for placement. So you don't need to do a new GC chlamydia if you don't feel like there is risk. You don't need to wait for the results. You can put it in the same day. Another thing that comes up from other colleagues is pap smear screening, and that also is not listed as a recommendation. Cancer screening is separate from contraception and should be addressed but not prevent someone from getting contraception. Another nice chart, which many of you may be familiar with, is the with the tools now. How to be reasonably certain a woman is not pregnant slide. And that is just one way that you might be able to decrease pregnancy tests in your office. They can be costly, and a lot of times we should trust women who say they've not had sex or they have a LARC in place and they're switching. You may be able to reduce some testing. So chlamydia, as I mentioned, there was a large study done with some of the California institutions along with Kaiser of 60,000 patients. And they looked to see if there was additional PID, if the IUD was inserted with GC chlamydia testing or none, and there was no difference in rates because PID in general is very low. The selected practice recommendations for contraceptive use also give guidance of what to do if you do get your test back and the patient has chlamydia and you've already put the IUD in. So the knee-jerk in the past for many people was to remove the IUD immediately, and actually the recommendation is to leave it in for treatment. It's actually, even if the patient wants it removed, it's safer for the patient to keep it in for at least 24 to 48 hours of treatment prior to removal. So we all know that our staff are very important to us, and they can do a lot of things to help us facilitate same-day LARC provision. So in some sites, medical assistants can be trained on counseling, and I think having contraceptive training with your medical assistants and your nursing staff is very, very important. We think we're the only source of information for our patients, but they get a lot of information before they see us. So I've spent time doing training for both groups. In one of my trainings, a nurse who had worked at Greater Lawrence, I think, for 30 years said, oh, I've told everyone never to get an IUD whenever they ask me because I told them they won't be able to get pregnant. So she was really surprised to hear some of the evidence-based information that had changed from when she had her babies a long, long time ago. So addressing, concerns with your staff, and they can get really excited and get on board, and you can avoid a lot of conflict. They also can do testing if they think the patient is going to have an IUD or another implant. They might be able to get the pregnancy tests on if it is warranted. A lot of patients call in, and a nurse can go through a quick start algorithm. So we'll go through those in just a minute. So here are some of the quick start algorithms. This is taken from the Reproductive Health Access Project. If you have used the quick start algorithms in the past, they have updated them recently. So just make sure you refresh your algorithms. So now they address emergency contraception in terms of what is safe with ulipristal versus Plan B. And that is, if anyone has any questions, I can answer them about the black box warning with ulipristal, Ella, and other progesterone-only contraceptive methods. Just let me know if you have questions about that. And then a separate algorithm for the copper IUD, which can be used as emergency contraception. So I think we all, ideally want to offer same-day procedures, and I think realizing and getting staff on board that the copper IUD is the most effective emergency contraceptive device. There have been nearly 0 pregnancies with this method as emergency contraception. So for a patient with a high BMI, where Ella and Plan B are not expected to be very effective, this is kind of their only hope. So being able to mobilize your staff at least for this situation, but that can be an impetus to change your procedures for other LARC patients. So I don't know if any of you have insurance issues, but we have them here. So a lot of times we kind of want to go out of our way so a patient doesn't get a bill. We do a lot of hand holding at our institution at the community health center. So we have my MA in particular who is trained to call the insurance to get approval. For some insurances, we need to do that. Other insurances, we kind of have a carte blanche. We know that neighborhood MCO always pays for all LARCs. Some have carve-outs for Mirena, but not Paragard, even in our current state of insurance. But that can be helpful to have one person who has all the numbers who can call quickly. And when an MA notes that the patient is interested, they can kind of start that process quickly, maybe before the patient is fully triaged. And then having LARC devices in your office for use, and we have another slide to be more specific about that. I'll talk about working with drug reps later. So there's several different ways to stock the devices. For clinics who have been told we can't have devices, they're too expensive, we don't have enough money to pay for them up front, using a specialty pharmacy is the way to go. But the fastest and the easiest is to use a buy and bill program where the clinic purchases the devices, you pay up front for them, and then the patient is billed upon insertion. That way it's there, the patient changes their mind, nothing happens until they're there for their placement. The specialty pharmacy is to avoid upfront costs. So you fax the script to the pharmacy directly bills the insurance, the device is sent to the clinic, make sure it's not sent to the patient. So you don't have any upfront costs as the clinic, you don't accidentally place a device in someone who is uninsured. But what we had to switch to this program for a while due to some insurance issues here in Massachusetts. It was taking 4 weeks for the devices to arrive. The paperwork was 2 pages long. It involved 3 signatures, 2 by the patient. It was very, very onerous and would not facilitate same-day placement. We are lucky enough to have an in-clinic pharmacy, a 403B program as well. So for a lot of our insurances, we can just e-scribe to the clinic pharmacy and then have the MA go over and pick it up very quickly. And then nobody has to call. There are insurance programs like Blue Cross, which we can't use our clinic pharmacy for. So we do kind of have to use at least 2 of these methods. So I have found that pharma reps can be very helpful. I work for 3 different organizations, and one of the organizations initially did not have 403B status, and their pharma rep actually suggested it to them and helped them get all of the paperwork completed because they knew that the patients were underserved and in need of contraceptive devices. So it's kind of a good thing on the pharma side. They get to sell more devices, but really helping facilitate training on staff for ordering and billing and coding. And if you say, tell your pharma rep, I'd really like to offer this device. If you can make it happen in my office, we'll do it. They will try to make it as streamlined as possible. And I think asking for help with 403B if you don't already have that. Because we're a training environment, occasionally devices are misfired. They are dropped on the floor, and we call up, we say rinse off the devices if they were in someone's body cavity and give them to a specific MA who calls the pharma rep and asks for a replacement. I know that some people have tried that and not been successful, but I think emphasizing that you are training physicians who are going to continue to provide this method and really expand the use of their device goes a long way, and we have not had any trouble getting all of our devices replaced, so the clinic does not have to eat the cost. The pharma reps are also helpful if you're doing, an IUD training for your residents. They'll provide all of the models and the devices. So the billing part, there was no quick and easy billing reference. All of these are really great. The first one is a little bit old, but kind of goes through ways to order the devices, kind of some more clinic procedures. LARC First is a really great new organization that has a lot of resources in terms of training, stuff for patients and clinicians, and they have a great billing guide. And they also have the third one is a quiz, but it's a quiz that emphasizes difficult insertions, the modifiers you can use, if you have to do it in 2 visits because there was a stenotic os, how you can do modifiers for all of the situations. So it really can be really helpful for billing. So I encourage you to look at those resources. Additionally, also on the LARC First website, or you can go to each individual pharma company, our patient assistance programs. So the ARCH program will provide free Skyline Mirena for patients who meet criteria. These would be patients who are uninsured and meet, I think there's an income requirement as well. The same thing applies for Paragard. Liletta also has one, but the cost of the device through this is $75, which is much less than the standard pricing, but still more than the $50 403B pricing. And you can get all of those forms there. In the past, the ARCH Assistance Program required that you insert the device for free. And I read the fine print on all of the programs, and none of them have that requirement. It probably was illegal. So you can or not charge a fee for the insertion if the devices are free to the patient. We have found here at Greater Lawrence, as well as the Title X clinic that I work at, that insertion kits really help facilitate same-day procedures. So we have insertion kits. Sometimes they run out, but we also have a book of procedures that the medical assistants have, which has a list of all the things that should be in a kit if one is not available. So we have the IUD insertion kit. I crossed out sterile gloves. There's an emphasis to no-touch technique, but clearly that is your choice and may be needed for a Paragard insertion, as well as an Nexplanon kit.
Okay, so we're going to switch gears a little bit and talk about LARCs in the postpartum period. This is right along the lines of all the great work that everyone is doing through IMPLICIT. So the rush for postpartum contraception is really important because 10 to 40% of women actually miss a postpartum visit. I'm sure we're all familiar with that. Less than 50% of women who desire an IUD actually receive it. And prior to implementation of postpartum LARCs at our hospital, we had collected some data which revealed a significant gap between LARC intention and LARC use. A lot of women were missing postpartum visits and opportunities for contraceptive care. And we all know that shorter interpregnancy intervals, defined as pregnancy within 1 year of delivery, are mostly unintended and are an independent risk factor for preterm delivery and adverse neonatal outcomes. And we know that in the first year postpartum, at least 70% of pregnancies are unintended. So ideally, this conversation takes place prior to delivery so that we can help patients. In terms of the importance for postpartum LARC, I know that I'm singing to the choir here, but 40 to 50% of women report having unprotected intercourse before their 6-week postpartum visit, even though the advice is not to. And ovulation can occur as early as 25 days in a non-lactating woman, but at a mean of 39 days. Regardless, that's all before 42 days, which is on average when you're going to see them if they come in for their appointment. ACOG recommends immediate postpartum LARC based on safety and efficacy, and in their committee opinion, immediate postpartum long-acting reversible contraception, they make a really great case for that. Also, we know that women who may be more motivated to start contraception in the immediate postpartum period as they have just gone through the entire process of pregnancy and delivery. There have been studies showing that women who agree to immediate post-placental placement are more than 10 times more likely to have the IUD inserted than those women who decide to wait until the postpartum visit. There was a great study in 2015 published in Contraception that was based on a decision analysis model to determine the cost effectiveness of immediate postpartum IUD placement. In their study, they defined it as within 10 minutes of placental delivery, and they compared that to IUD insertion at the postpartum visit. The main outcome measure was unintended pregnancies prevented, and they found that immediate post-placental IUD placement prevented an additional 88 unintended pregnancies per 1,000 women over 2 years. This study assumed the cost of a live birth was $6,000 or more, and they also assumed an immediate postpartum IUD expulsion rate of 18% and an 80% show rate to the 6-week postpartum visit. So most of their estimates, I think, were in line with the data, and in fact, some of their estimates may have underestimated the cost effectiveness of IUDs. And it also assumed the cost of an IUD to be $800, which we know can actually be brought down through the methods that we discussed earlier. In terms of the timing and safety of postpartum LARCs, we know that the CDC U.S. medical eligibility criteria, which was updated in 2016, states that IUDs inserted in postpartum women is safe, with the exception, of course, of a woman having active postpartum sepsis or active uterine infection, in which IUD placement is contraindicated. Looking at the copper IUD first, pretty much placement at any time is a 1 or a green light. For Mirena, mostly 1s, but they gave a 2, which still means benefits outweigh risks for breastfeeding women for immediate post-placental placement. And we're going to talk about that later when we talk about breastfeeding. And notice that between 10 minutes of placental delivery and up to 4 weeks postpartum, there is also a 2 due to increased perforation and expulsion risks during that time frame, but still benefits outweigh the risks. And for the implant, they evaluate only non-breastfeeding women, and it is a green light at all times. So for post-placental IUDs, although we're not doing these here at our institution, I'm sure some of you all are working to make it happen at yours or perhaps already doing it. But as we know, there are varying different definitions, mostly between 10 and 30 minutes of a placental delivery or during a C-section. There has been some evidence suggesting that post-placental IUD placement does not increase the risk of endometritis, and it does not increase the risk of excessive bleeding. We do know that immediate post-placental IUD expulsions are higher, and we will get to that on the next slide, but total pregnancies at 1 year are not. And we're going to get to some of the percentages, but we do know that expulsions are higher after vaginal birth and lower after C-section. But what a lot of the studies have found is that even if IUDs are expelled, women know about it, so they can be replaced if they are expelled. We tried to put together a really nice table that would simplify all of this information, and unfortunately the literature doesn't completely agree on things, so this was a harder task than initially imagined. For the sake of simplicity here, we will call immediate post-placental within 10 minutes of delivery of the placenta. Interval placement is after 4 weeks postpartum, and early postpartum is the in-between time period. So looking at expulsion rates, we know that immediate post-placental placement is associated with an odds ratio of about 5 compared to interval routine placement after 4 weeks postpartum. That is roughly equal to about 25%. We also know that vaginal delivery is associated with higher expulsion rates than C-section, and the earlier postpartum period within 10 minutes of placental delivery and before 4 weeks postpartum is associated with an even higher expulsion of 2 to 5% of that in the immediate post-placental period. And then we all know that the expulsion rate in routine postpartum period is low, 1 to 4%. As far as perforation, no great estimates about percentages, but we know that it's highest in the early postpartum period, followed by immediate post-placental and lowest at interval placement, and this is not affected by breastfeeding. And it's important to know that even though expulsion is relatively high, immediately post-placentally, IUD use at 6 months is double that for interval placement. So I suppose the main takeaway here is that the early postpartum period has more expulsions and more perforations, so much more caution would need to be taken if inserting an IUD at that time period.
Okay, so real quickly, more just to have on as a reference. So technique, so in the perforation rate can vary with the type of insertion. So there's several different options. So ideally within 10 minutes, most studies go out to 30 minutes, but you put new gloves on, you can use the inserter, and that would have the highest rate of perforation. And you hold the inserter and pass it to the fundus and release the IUD. You can also remove the IUD from the inserter, place it in ring forceps, and then use the ring forceps to place it at the fundus. Additionally, especially with a patient, I would imagine, with a lot of anesthesia, like an epidural, you can take the IUD out, place it in your hand with your sterile glove, and place it at the fundus with your hand, release it. That would have a very low perforation risk. In one study, they did this in a residency program, and they found that there was reduced expulsion when ultrasound was done during the placement to assure that it was placed at the fundus. We know that many procedures, including post-placental IUDs, they improve with practice, and in a large residency environment, everyone is not going to get to do a lot of these and become super great, so the ultrasound can kind of help level the playing field. You cut the strings at the level of the introitus, and as you can imagine, with the uterus involuting, the strings will get longer with time. There is no need for additional antibiotics. And then during a C-section, take out the baby, take out the placenta, drop it in. There's a couple of variations of what to do with the strings. You can leave them long or tuck them through the cervix with a ring forceps. You can trim them right up before you put it in, and then have follow-up for string shortening. So for IUDs and breastfeeding, the levonorgestrel is the one that has raised some concern in the lactation community. What we have seen in studies are that there's no difference in time to lactogenesis, how fast a woman makes the milk. There's no difference in breastfeeding at 3 months. And the WHO fails to demonstrate adverse breastfeeding outcomes or negative health outcomes in infants that have been exposed to it. No restricted growth, health problems, or impaired development. As you can imagine, the copper IV would not have any differences at all and often is used as the control for some of these studies. And women also don't have increased rates of expulsion. When I've talked with members of our lactation community, they often cite a case report, and we use a different level of evidence in family medicine, so we've had a lot of long conversations about what evidence is available and what offers the best picture of what's safe for our patients. So the implant in breastfeeding, the Nexplanon, we offer immediately for patients who are interested. There also has been shown no different in mean time to lactogenesis. So this isn't reflected on the CDC slide that we had previously, but there are a lot of studies at this point addressing it. No difference in proportions of women exclusively breastfeeding, and the infant weight gain is actually greater in many studies in the implant group. And this is a summary of the Cochrane review from 2015. My favorite study of the implant, etonogestrel in breastfeeding, was small. I wish it was bigger, but it was randomized between immediate placement of the implant versus 6 weeks depo. And the etonogestrel group had a higher maternal weight loss and a higher infant weight gain. So they really got the best of both worlds. In Lawrence, we started an immediate postpartum implant project in 2013. And for patients who were interested, it was ordered in the electronic medical record. It was billed in general through the clinic pharmacy, and then we would send, and we still do, send residents or attendings over to pick up the device. We then take it to the hospital pharmacy because it has to be verified as an outpatient medication, and then it's brought to the floor for placement. We aren't currently able to bill. We don't have a code outside of the global payment in Massachusetts for delivery to bill for LARC devices. We looked at intention to use and receipt of device early on in our project, and we found that the receipt increased from 26.5% to 93.5% with the institution of the immediate placement at the hospital. We also looked at resident numbers and communication with staff. So kind of going back a couple of years, so prior to our project, we had very little insertions and removals, and I think overall Nexplanon use has expanded, but it increased to 189 from 31 in a year, and still more insertions than removals. So we do have barriers here. Our hospital does not carry LARCs because they are not outside of the global fee. We don't have any free devices, so people involved in Ryan or READY programs, or even LARC First, if you really don't even offer a lot of IUDs in your program, you might be able to apply for those. And we don't have the Medicaid funding for insertions outside of the global payment fee here. Kind of on my soapbox a little bit, so there is a growing movement to get Medicaid coverage for postpartum inpatient LARC placement. And every couple of months, a few more states get added to the list, and I highlighted Pennsylvania. So that's really wonderful that you have the opportunity perhaps to do that or to look into that. Massachusetts, as liberal as we are still working on this. But South Carolina was the first state to offer this service.
In terms of LARC continuation, so just switching gears here, ultimately it is the patient's decision regarding her own family planning desires. But as we saw in the data presented earlier, discontinuation is surprisingly high, and sometimes it's not because the woman wants to discontinue the method, but she's bothered by something that we can actually help with. In terms of premature LARC removal, literature documents up to 25% Nexplanon removal at 1 year, and this is mostly due to irregular bleeding. In the CHOICE project from St. Louis, which I'm sure we are all very well aware of, IUD discontinuation rates at 1 year were also up to 25% for the youngest women in the study. And common reasons for discontinuation are unfavorable bleeding patterns for both Nexplanon and IUDs, and dysmenorrhea for IUDs. So the things that we have found that can help are, first of all, counseling. So counseling before the device is put in, and also counseling that if a woman changes her mind, wants to get it out, we should help her keep it in if she does not desire to become pregnant. Unfortunately, I have had patients who, for example, wanted an implant out and then tried some other methods and wanted the implant back in. And unfortunately, within the 3-year time period that's FDA approved for Nexplanon, she was not able to get another device. And I don't think patients are very well aware of that. Having routine follow-up visits to check in about bleeding can sometimes avert other outcomes and help us get ready to help patients. And finally, ways to control bleeding, which we're going to be talking about. Counseling also includes LARC duration, so I just wanted to throw this in there. There have been a few studies enrolling from 200 to 500 women in several countries and several different sites that have shown that Nexplanon can be used for 4 years and maybe even 5 years, but they basically found 0 pregnancies at 4 years, including in obese women where serum etanogestrel levels were still very high to prevent pregnancy. So again, this is also part of the counseling piece that although the FDA has approved this device that I'm about to put in your arm for 3 years, there is more and more evidence coming out that perhaps this can stay in for 4 years so that if and when these recommendations change, she will be prepared. In terms of irregular bleeding, the CDC selected practice recommendations obviously recommends a thorough workup. So STI testing if there are risk factors, making sure that a patient is up to date with routine cervical cancer screening. Pregnancy tests are usually not indicated if the device is correctly in place. And then, you know, based on provider judgment, pelvic exams, endometrial biopsies if the age suggests it, or other risk factors, or ultrasound. But now talking about bleeding persisting, this is talking about bleeding persisting after 3 months with the contraceptive method. The CDC's algorithm helps us understand, gives us some guidance that NSAIDs, 5 to 7 days of treatment or hormonal treatment can help. So some options would be NSAIDs, and in terms of the specific NSAIDs, regimens include naproxen 500 milligrams at onset, 3 to 5 hours later, and then 500 milligrams twice a day. Ibuprofen 600 milligrams once per day, or mefenamic acid 500 milligrams 3 times per day. We also know that combined oral contraceptives can stabilize the endometrium, and we can use higher ethinyl estradiol doses up to 35 micrograms for up to 3 months in the usual cyclic method or in a continuous method. There really is limited evidence for the use of doxycycline or mifepristone, but in case you are interested in trying this, the dose of doxycycline is 100 milligrams twice daily for 5 days. So in terms of provider resources, the Reproductive Access Project is where we have gotten a lot of our materials and algorithms, as well as ARHP and Physicians for Reproductive Health. And
that is all. Any questions?
Hey, this is Lisa Schlar. Phenomenal job. That was excellent. Very impressed with how thorough you guys were, and I think you should take it on the road. That was a great talk.
Thank you.
thank you.
Are there any additional questions or comments from our speakers?
There's a question on any data on a risk of embedded IUDs loss strings on post-placental IUDs. I don't know of any data. I haven't read that it was any worse for loss strings on post-placental IUDs we're offering a new service here at Greater Lawrence for missing strings, which is using a manual vacuum aspirator to avoid an inpatient hospital procedure when the strings are not able to be easily obtained with cyto brush, cyto broom, or a Kelly clamp, so that if you have MVA in your office, that's a new service that is safe and effective. But I don't know anything more about embedded IUDs and post-placental.
Great, thank you. Any other questions? If you happen to be on mute, you could type in a question. If that's easier for you.
Hello?
Hi.
Hi, Jessica. It's Ngora from Mississippi. How are you all?
Great. How are you?
I'm good. I'm glad to be here, and thank you all for the presentation. My question might be a bit different than what was presented, but it's definitely all about LARCs. And I'm wondering how the medical community is also working to address, for instance, women who do receive Medicaid, they are Medicaid beneficiaries, if you will, and they do visit their doctors in some cases. Well, if they're pregnant and to carry on the birth-spacing conversation, I guess what's being done to make that more of a comfortable conversation between doctor and patient, to make sure that women feel free to express themselves concerning their reproductive wants and desires. I'm always interested in those conversations.
I think you might have broke up, this is Julie again, from the middle part of it. Are you asking about like coercion? I guess I'm not fully understanding your question.
Yes, coercion and also just creating a place where women feel comfortable, expressing their reproductive desires. So whether or not if they want to get pregnant again, they feel comfortable saying that, or if they don't, then they, I'm sure many sign on to say, I want something so that I don't get pregnant again. But then on the other hand, there, are women who desire to have children.
Right. No, that's a great question. So one of the things that is used, nationally is the kind of use of the one key question, just asking women at every visit, are you interested in becoming a parent in the next year? That can kind of help start that conversation. And it should be used in a way to find the patients who do want to become a parent in the next year and help them address the need for folic acid, checking of their medications, see if there's diabetes that needs to be brought into better control. But I think that that's something definitely that we all need to keep thinking about is coercion. The LARC First program has a really great training program. It's aimed at residents. And I watched when they were showing it, and I couldn't find it on the website, but I will try to get a link to Jessica, where it's a video where a patient comes in and they're having a discussion about an IUD insertion, and she says, can I get it out anytime I want to? And the provider says, yes, anytime you want to, for any reason you can get it out. In the second video, she comes in to get it out, and it's a different provider, and they say, well, no, you haven't had it. Did you try this? No, you didn't. I don't want to do it. And it has a great example of respecting patients' beliefs. We should do whatever method is the best for the patient, is the best for the patient, that, including not having contraception, but leaving the conversation open. So I will try to get that resource because it's really good for training and teaching, but I didn't find it on their website.
Again, this is Lisa from Pittsburgh. I'm really glad that you brought that up, and I think a better term than coercion is this reproductive justice issue, and
yes,
I think it's a really challenging issue for all of us, especially in the training center, because we have a lot of residents that all of us, right? You think you know what's best for your patient, and I think we need to take a step back, and I really would love to see those links because I'm excited that LARC First has addressed that, but I think we really do need to address that because it's critically important because it's all about the doctor-patient relationship, but it can be very much on the line, right? It's being able to describe the importance of interpregnancy interval and educating without sounding paternalistic like we know what's best for our patients.
That's great. It's Lisa, right?
Yeah.
Was it Lisa? Okay, Lisa, thank you for that.
But I'm glad you brought it up, and I would be very interested for the folks in Lawrence on what they do because I am confident knowing the faculty there that it's a sensitive issue everywhere, but they also want to address that. I think the purpose of this conversation obviously was LARC promotion, but I do agree that a slide in there, if you guys are going to go on the road, I do agree with you. That would be nice to have that in there in some way so that we can definitely keep that on the forefront. And there are a lot of folks here that as soon as they start to hear these talks, they clam up because they think we're not being sensitive. So I think you're absolutely right. And Jess and I have had to address this several times when we've gone to talk about ICC at different meetings.
So this is the link I just posted that we used previously. I didn't check it today, but I hope it's still effective for the videos. Yeah, and Asmina just pulled it up. So if you just go to www.getlarc.org/training, that will bring you to the videos in the curriculum.
Okay.
Great. I'll make sure to include that in the newsletter as something that people can use as a resource as well.
Thank you.
Wonderful. Any other last-minute questions? Okay, well, I would just like to thank everybody for joining us this afternoon, and specifically to our presenters. Thank you so much for this wonderful content, and we appreciate your time and effort. And if somebody has me on speakerphone, maybe you could turn it off for a second. Okay, I think that took care of it. So just again, thank you so much to our speakers who took the time to prepare this wonderful content and their efforts this morning. We will be distributing a recording of the presentation as well as the slides in the next version of our newsletter, and feel free to reach out with any additional questions. Thanks.
Thank you.
Thank you.